Chapter 32, Care of Patients with Musculoskeletal and Connective Tissue Disorders. Theory objectives. Compare the assessment findings of a connective tissue injury with those of a fracture. What would we see with each? Determine the rationale for the do's and don'ts of cast care. Outline the potential complications related to fractures. Discuss the pathophysiology and implications of the 6 P's. Contrast the preoperative and postoperative care of a patient with a total knee replacement with that of a patient with a total hip replacement. Relate the special problems of patients with arthritis and specific nursing interventions that can be helpful. Illustrate the process by which osteoporosis occurs, ways to slow the process, and how the disorder is treated. Determine important postoperative observations and nursing interventions in the care of a patient who has had an amputation. Clinical practice objectives. Gather data on a patient who has a connective tissue injury. Reinforce teaching about proper care of a cast and extremity. Observe a physical therapist who is teaching quadriceps exercise, and then assist the patient to practice that. Evaluate the skin of a patient who has a prosthetic device or an amputated limb. Sprain. So what is a sprain? Well, we know that sprain occurs when a joint may be forced during trauma past its normal range of motion. There may also be some twisting inside of that joint that causes some trauma, right? It is a partial or complete tearing of the ligaments that hold your bones together in that joint. So there's many different ways to cause it. We've got ankles, knees, wrists, right? That's your most common locations of sprain. And then we can actually grade the sprain on how bad the sprain is, what is involved, and what are the symptoms. A grade 1 is a very mild sprain. There may be tenderness at the site, a little bit of swelling, no real loss of function. You can still do everything you need to with the body part. There's no abnormal motion inside of it. There may be some slight stretching and microscopic tearing of the ligament, but it is not a complete tearing. A grade 2 is a moderate sprain. It is very severe. Actually, it's the most severe sprain that there is. Even though grade 3 is a worse sprain, the pain is most severe with a grade 2 sprain, especially when you put some weight on it, right? That makes it more painful. There's swelling and bleeding into the joint with some loss of function. The ligament is partially torn. And then you have your grade 3 sprains. These are severe. The pain may be less severe, but the swelling, loss of function, and bleeding into the joint are more marked. They are very, very bad. Complete tear of the ligament happens in a grade 3 sprain, and there's complete instability of the joint. You are not able to use that joint. We do a physical examination, a history of what happened and led up to the sprain, and then we do some imaging to see what is going on, likely an MRI, potentially an X-ray, right, to really visualize the muscular and bone structures inside of the joint. Signs and symptoms. Grade 1, we just talked about. Grade 2, we just talked about. Grade 3, we just talked about. I forgot this slide was in here, so let's move on. How do we treat the sprain? Well, we rice it, right? Rest, ice, compress, and elevate. Rest, ice, compression, and elevation. That's what RICE stands for. You don't want to be using it, right? You want to rest it as much as possible. You want to put ice on immediately after the injury and use ice for 24 to 72 hours to help prevent swelling and reduce pain. You also want to wrap, right? Wrap it. So use an elastic bandage like an ACE bandage. Don't cut off circulation. And then you want to elevate or lift it in order to reduce swelling. And these measures all together will help to stabilize the joint and reduce pain. Okay, ligaments aren't just going to grow back together, right? They're not. So we want to strengthen the joint. And we want to make sure that we don't immobilize the joint too long, because if we do, it can begin to atrophy. The muscles around it can atrophy, and that can cause issues with permanent disability. Because these ligaments don't just grow back together, they have to scar back together. Sometimes they don't scar back together and we have to do surgery, especially with those grade 3 sprains. We'll put those people in a cast and then they'll be referred to surgery. We can give these patients NSAIDs, right? We can put them on crutches and teach them about crutch gait. We can have them rest, right? As long as they're still doing some mobility exercise. Okay. We don't want the patient to be on NSAIDs for too long, because longer use of NSAIDs has been shown that it may delay or suppress the body's ability to heal the injury. So a short period of time with NSAIDs, maybe the first couple of days, to help with the pain and the swelling. Strain. Well, strain is different than a sprain in that it's a pulling or tearing of a muscle, a tendon, or both. Remember, a sprain is the ligaments. A strain is muscle and or tendon. Trauma, overusing it, overextending it. We often see strains in the back strain, right? Back strain. So these people will have a history of working their back too hard. For example, they're a nurse and they're constantly lifting and turning patients. They'll have some soft tissue swelling, maybe some pain or bleeding if the muscle is torn. Hamstrings, quads, calves, right, are also common sites for strains. You may also see strains inside the joint, but sprains are more common. Signs and symptoms beyond that, they may end up having a big old bruise, right, from that bleeding that had occurred. What can we do? Immediately, we want to ice and compress this if possible. Make sure you teach that patient or reinforce teaching for that patient to use the ice for only 20 minutes every hour. That way it's intermittent icing. And then you want to check the distal parts of an extremity whenever you put on a compression device for sensation and circulation to make sure that they still have good blood flow and you're not cutting off their circulation. They may end up with some NSAIDs to help with discomfort, maybe some muscle relaxers if they have issues with spasms, but really we're just going to wait this one out. The body does begin to heal itself. So the patient is told not to re-injure themselves by jumping back into normal activities and the proper ways to move their body so that they don't hurt themselves again. If it's a really bad strain, we may have to go in and do surgery. Dislocation and subluxation. Well, dislocation is that stretching and tearing of ligaments with a complete displacement of bone. Subluxation is a partial dislocation, so a partial displacement of bone with stretching and tearing of ligaments. Where do we dislocate? We dislocate in our shoulders, our knees, our ankles, that temporomandibular joint in the jaw. Oftentimes there's a history of some kind of outside force, right? They were hit in the face or they fell on their knee or they fell on their leg and it dislocated their hip. There's usually some kind of trauma that occurred. They also will have severe pain that gets worse with movement. They may have spasms of the muscle, and when you look at the joint, it may be swollen, red, or warm. When we take a radiograph of it, we'll see that displacement of bone. How do we treat it? We give these patients a little bit of propofol often, maybe a little bit of Versed and fentanyl. We give them a little bit of monitored anesthesia care, and then we just pop it back into place. This actually is often a pre-op PACU procedure. They don't actually even go back into a surgical suite. We want to rest this. We want to give them good pain control options, right? Applying the cold and then applying the heat afterwards. Cold for the first 24 to 72 hours, and then we can apply some heat. Make sure that they've got good perfusion, that they're able to move everything. Our goal is to stabilize that joint after that reduction and then rehab, right? Lots and lots of rehab in order to minimize atrophy of our muscles, and we want to strengthen that joint so that it can do good work for us in the future. Okay. Moving on to bursitis. So bursitis is about that bursa. Remember, we talked about that sac-like structure inside of the joint that's filled with fluid, especially specifically in our freely movable joints. If we injure or overuse that joint, we may have an issue with bursitis. We see this in our elbows, our shoulders, our hips, and our knees. There's mild to moderate aching pain with some swelling. Maybe we have a history of an injury, like I fell and I hit this, or I threw this ball or lifted this thing and it hurt, right? And then as we're physically looking at it, or while the doctor's physically looking at it, he's able to see maybe some swelling present or something like that. We want to treat this with rest, ice, massage, anti-inflammatories, maybe a compression wrap if possible. And then we can also inject cortisone or steroid into the bursa to reduce inflammation and help reduce pain. As far as nursing management, we want to make sure we're assessing their pain and their perfusion to their lower or upper extremity, depending on where the injury is. We want to help them with mobilization and use of assistive devices. And we want to make sure that if they have issues with their ADLs, that we are promoting continual improvement, but also that we're keeping them from overdoing it. Other connective tissue disorders. So we have things like rotator cuff injuries or rotator cuff tears, where we have a repetitive activity like throwing a baseball or some kind of overhead motion that's you do over and over again. It can cause this degeneration and potentially even a tear. So when you have that, or you have a fall or a trauma that's caused a tear in the rotator cuff, one of the four muscles inside of that cuff becomes torn, and the patient gets really, really has a lot of pain, right? And they can't perform abduction or the pulling of their arm into with the external rotation of that shoulder. We want to rest these patients, maybe put them in a sling, give them some injections of steroids, some NSAIDs for discomfort. And then after the acute episode or the initial pain, initial inflammation is over, they need to go into PT for rehabilitation of the joint. We want to put heat on the joint before we exercise it. It allows for relaxation of those muscles. And if this tear does not heal on its own, this is one of those connective tissue disorders that results in a surgery. ACL is another one, anterior cruciate ligament injury. So falls or athletic activities, motor vehicle accidents can cause these. We do see these a lot with the athletic activities in our sports player, volleyball, basketball, soccer, right? It's caused from a hyperextension, internal rotation, maybe even an external rotation of an extreme degree, or some other combination, right? The ligament may tear from either the femur or the tibia, and there's often a loud pop heard when it happens. It gets very swollen shortly after the injury happens, and then the knee starts to feel unstable. The patient is not able to bear weight on the knee, on the leg, because the knee will give way, right? They can't fully extend the leg often. The doctor's gonna look at it, maybe do an X-ray, an MRI. We may do an arthroscopy with a little scope. And then while we're in there with the scope, they may have a tissue graft where we borrow a ligament from another place in the body to repair that ACL, okay? We want to immobilize that knee afterwards, get them on maybe a continuous passive motion machine to promote full mobility, or put them in a long leg brace. Isometric exercises are good for these people, particularly quadriceps setting. However, remember, we don't want to do that with our patients that have high blood pressure or increased intracranial pressure, as it can increase their, or heart failure, because it can increase their blood pressure and heart rate. Meniscal injury, your meniscus is that shock absorber of the knee, right? It lays on top of that tibia, between your tibia and your femur. And when you have an ACL injury, oftentimes there's a meniscus tear with it. So it's a fixed foot rotation injury. We see that with sports activities like football, soccer, basketball, skiing. You may have some popping, but it's not like that distinct pop that we hear with an ACL. This is just popping with movement, right? You also may have slipping, catching, or buckling of the knee, some mild swelling with joint pain. As the doctor moves the leg, he can hear a click in that area, and you have some localized pain. So MRI is going to be our best diagnostic test for this type of injury, and they're going to need an arthroscopic repair of this surgery. Afterwards, we really want to focus on pain management, because it can be extremely painful, and then getting them on those recovery exercises. An Achilles tendon rupture. Now, the Achilles tendon is that part in the back of the leg there, where the heel meets the lower part of the calf, right? So it attaches to the calcaneus or your heel bone. It is it pulls those muscles from the back of the calf into that heel bone. When it gets overstretched, it can rupture, and that's where we get that Achilles tendon rupture. Or so we've got like a sports injury where we've overstretched it and it's ruptured, or a person's fallen from a tremendous height, like jumping out of a burning building or off a bridge or something like that, and they're landing on that heel bone. It can cause that Achilles tendon to rupture. If you have arthritis, diabetes, or you're on antibiotics, you're predisposed to that kind of injury. Also, if you've got bursts of jumping in your sport or pivoting or running like tennis or basketball, it's more likely that you'll have one of these injuries than the other types of sports. Sudden pain in the back of the ankle or the calf is your big symptom. There's also a loud pop or snap sound when it truly ruptures, and there's a depression that can be both seen and felt. So like an indentation that can be both seen and felt about 2 inches above that heel bone or that calcaneus. Okay. These patients have a lot of pain and swelling and stiffness. They're bruised and they really struggle to walk. Remember that Achilles tendon is critical in our ability to walk. They're not going to be able to point their toes or stand on tiptoe. And we will examine the patient while they're laying on their belly, because we're going to watch to see how their toes point. If they do not do what they're supposed to do, if they don't point downward, then we could have an Achilles tendon injury. We want to treat these people with splinting, casting, or maybe both, and then surgery as well. It does take quite a recovery period of about 8 weeks with a PT, lots and lots of PT on board. Bunion. Okay, so bunion is the most common foot problem. This is where we have swelling of the bursa in the great toe, and it moves laterally at that metatarsophalangeal joint. You can just be predisposed to it through heredity, so it's a family inherited issue, or you could be wearing ill-fitting shoes, which can cause bunions. Women are more likely to have them. People that wear open-toed shoes that are wider in the toe area are less likely to have them, because they're not going to be smooshing the toes together and causing that bunion. We want to inject corticosteroids to reduce inflammation, right? And also pain. And we can put metatarsal pads in to relieve some pressure. They can get some pain medicine or even go through a surgery with bone realignment and removing that bony overgrowth so that walking isn't super painful. So yes, and they do that in combination with several other podiatry surgeries. Carpal tunnel syndrome. So this is that nerve issue, right? So the median nerve is compressed, and therefore you've got that distinctive pain and numbness and tingling of the hands that gets worse at night. So repetitive motions of the hand or wrist, like writing or typing or machine work, can predispose you to a carpal tunnel syndrome. Maybe you are a seamstress, right? So you're sewing and you're using your hands a lot. That can also put you at increased risk. Diagnosis of this, we'll do an examination, typically with a hand doc, right? Compression test, electromyography, where we're testing, the nerve and muscle relationship. We want to rest it. We want to splint it. We may do some occupational therapy or steroid injections to see if we can get by. And if it is still extremely painful, surgery is an option. Oftentimes they only do one at a time, but I have seen more than one done at a time. It just makes recovery a lot harder because you're not able to use that hand. Swelling is the biggest complication of surgery. Patients don't keep that hand elevated like they're told to, and then it becomes very painful as fluid accumulates within that space. Nursing management, just really encouraging the patient to elevate and immobilize that wrist. No heavy gripping or pinching. Checking that they've got good blood flow, good color, good warmth of the fingertips, and good cap refill. Okay, fractures. Fractures are breaks in bones, right? We have an interruption in the continuity of a bone. Well, we know many things can cause fractures, like trauma, osteoporosis, or having a severe injury. Pain is one of those things that goes right with fracture, especially due to swelling. We have bleeding. We may see a physical deformity that's like, oh yeah, that's broken, right? Ecchymosis or bruising. Crepitation, crepitation is that abnormal grating sound, right? Bone on bone sound. There also may be loss of function of the extremity. Examination of the area, imaging, right? A good old x-ray will tell us if we've got an issue. Where the injury happened or how the injury happened can help us to figure out what kind of type of fracture that we have. For example, if somebody punches a wall or another solid surface, like a person's face, they may end up with what's called a boxer's fracture. So we can predict what's going on inside of the body if we know how it happened. Oftentimes they won't tell us the truth, but we can always ask, right? Okay. Types of fractures. There's complete fractures. That's where your bone breaks into two parts, right? They're completely separated. And then you have incomplete fracture. That's where the bone is broken, but the two parts are not completely separated. You have comminuted fractures, which is where there's a shatter of the bone, right? We see this in crush injuries or high impact injuries. Closed fractures, there's no break in the skin. They're also called simple fractures. And then open or compound fractures is where we do have a break in the skin. There's a bone sticking through, right? And then you have your green stick fractures. So green stick fractures are really common in kiddos because their bones are still very bendable, moldable, flexible. So imagine you go outside and you're wanting to toast a marshmallow and you're going to use a stick. You go to pull one off a tree and it's not dead. It's going to be green, right? As you try to bend it from the tree, you're going to have an issue. It's going to break in parts of the stick, maybe on the outside where it's brown, but on the inside where it's green, it's only going to bend. That's what happens with these green stick fractures. It's a partially broken, partially bent fracture because those bones are so flexible. Okay, other types of fractures, you got pathologic fractures. So you have something going on like a cancer or an osteomyelitis potentially. A longitudinal fracture, which goes down the length of the bone. A spiral fracture, we see this a lot in child abuse where they're twisting the arm, or maybe the arm gets caught in a winch in a factory job and it just turns the arm. It can cause a spiral fracture. That green stick fracture, partially bent, partially broken, the simple and the compound. Okay, oblique, we're going diagonally through the bone, and then transverse, we're going horizontally through the bone. Emergency care of bone. So we immobilize it in the position that we find it, splint it as it lies, right? If they have a part of the bone sticking through, we want to make sure they have a tetanus immunization up to date, or if not, we will give that. Also, if they have one of those open or compound fractures where it's going through the skin, we want to get them on antibiotics. That's going to be big. Our primary goal is going to be to reduce this fracture, right? We want to get the bones back together. There's two ways to do a reduction. There's a closed reduction and there's an open reduction. Closed reduction does not involve a true surgery. Now, we will give anesthesia, may even take the patient back to surgery, but we're not going to be cutting on the skin. They're just going to be giving the anesthesia and then trying to get the bone back where it's supposed to be. So open reduction is where we're actually cutting. We're doing a surgical incision through the skin, going down to that bone at the site of the fracture, and we're doing something in order to bring the bone back together. Now, sometimes we don't have to put in internal fixation, but internal fixation is very typical. So we'll talk more about internal fixation, but you think like pins, plates, screws, etc. External fixation, this is where we use those pins that go down into the skin, but it's attached to some kind of external fixator device, right? And we can adjust those pins and screws from the outside. And then you've got your casts, your splints, your braces, and also traction. We'll talk more about these all in just a few moments. Internal fixation, so pins, nails, plates. The most common internal fixation surgery is called an ORIF, or open reduction internal fixation. We see this a lot with broken hips. They may put in a prosthetic joint or bone, right? IV antibiotics are huge. We're going to give 2 grams of Ancef in pre-op, and typically they're also going to receive medication, antibiotics throughout the surgery and then following to prevent infection. What do we see? We see infection set in, potentially even osteomyelitis after an ORIF, and instead of healing when we do repeat x-rays, we start to see bone breakdown 7 to 10 days afterwards. So it's no good. Maintain good alignment of these patients, help them prevent immobility complications like those contractures that can occur very, very quickly after not moving the body. And then controlling their pain is going to be huge. There's that external fixator device. We would do this with like massive open fractures. If the patient has an infected fracture, we've already gone in once, or they have multiple traumas. Casts. So we have plaster and synthetic casts. So these are the casts that we actually have, or two different types of casts, but plaster casts are the ones we actually have to like mix up and then apply, right? They take a long time to dry, so you really don't want to get them wet. They are, they're very easily to mold, right, to the body size and shape. Your synthetic casts are less easily molded to that body part than plaster casts are. And they're really not great if you have a severely displaced bone. They do stabilize, but just not as well as those good old-fashioned plaster casts. They are easier to put on though, which is nice. What else? Let's talk a long leg, short leg cast. So that's just what it sounds like. It's how much leg they cover. They may even put a cast shoe on the bottom of the leg. It's like that canvas sandal, so you can walk after you've had your cast on. It just depends on how severe the injury is and what kind of cast has been applied. We also have the spica casts, which are used in children, right? Especially those that have deformities in their hips, or they end up having some kind of major lower extremity break. It'll cover the trunk of the body and then either one or two extremities. So if they break their left leg and it's a really bad break, maybe in the femur, we want to cast their trunk as well as that leg. Okay, and then patient teaching with casts, just obviously explaining the procedure to the patient, what we're going to be doing. Don't fresh cast over plastic, right? That's bad news. And then don't cover a drying cast because it can actually reduce its ability to dry completely. Skeletal traction. So skeletal traction used to be used very often to relieve pain, help to maintain that bone alignment, right? But multiple studies have shown that this is not really effective and that splinting and positioning and giving medication is actually a lot better for this. Skeletal traction, we're using pins, wires, or tongs, and we're actually going into the bone beyond the fracture. So let's say you break your femur, we go into the bone just a little bit lower than that and pull on the bone. We're going to attach those wires to at least 10 pounds of weight, and the body is going to work as your counter traction. And so this application of a mechanical pull to part of the body is going to help to hold that part in that position while we're immobilizing it. Skin traction is when we're not actually going into the bone. We're just going to put a bandage below the fracture and then pull on the bandage, right? You only want to use 7 to 10 pounds of weight for this, and you can either do it continuously or intermittently since it's not actually through the bone. Complications of fractures. So what can happen after we've had a break? Well, we're not able to get it set well enough. The guy breaks his wrist or his hand and he's like, yeah, I didn't know I had an issue, or I didn't think it was broken. I wasn't sure, so I didn't come in. Well, that's bad news bears because we have breakdown of that bone and maybe even the beginnings of healing in the wrong alignment, right? So delayed reduction is very bad. We also could have damage to nerves and surrounding structures due to the displacement of those bones. Improper alignment, right? So whenever we have improper alignment, bone is going to heal no matter what. So if it's in the right alignment, it's going to heal correctly. And if it's in the wrong, we will have incorrect alignment for a long period of time. So this is where you hear about them having to re-break something and set it again. Inadequate mobilization, right? This is big for making sure your patients stay moving, because if they're not moving, then they may develop a contracture or atrophy. Continued stress is not going to allow for healing of that fracture, so rest is super important. Making sure the patient's getting enough calcium and phosphorus and all of those good things in order to make healthy, strong bone. And then atherosclerosis, or the hardening inside of those blood vessels, right? infection in your fracture. So especially open comminuted fractures that require surgery, they're going to be extremely high risk for infection. Antibiotics obviously are going to be indicated, especially if it's an open fracture. We want to watch their temperature closely, trend their white blood cell count to watch for bumps, and continually be looking at that wound, right? For redness, drainage, warmth, right? All of those things that would indicate infection. Osteomyelitis is a particular type of infection. It's a bacterial infection of the bone. Usually Staph aureus enters that bloodstream from a distant focus of infection. So maybe there's a boil or another open wound that has that Staph aureus in it, and it's made its way into the bone. We see this in the tibia, we see this in the fibula, the vertebrae, maybe even a prosthetic like a hip. These patients have a sudden onset of severe pain. It's very tender at the site, maybe a high fever with some chills, lots of swelling, headache. They just generally feel really terrible. If the patient has diabetes, chronic kidney disease, or they're on steroids for a long period of time, they're at a higher risk. The earlier we can diagnose this, the better their prognosis or outcome. Okay, history and physical, we'll do an ESR or an erythrocyte sedimentation rate, right? We don't want to see an increase in that. Also, white blood cell count, that'll be indicative of infection. Do some imaging, right? We're going to start to see osteoclast activity or breakdown of bones 7 to 10 days after the initial surgery, especially if they've had like a hip, right? And that's going to indicate osteomyelitis. Biopsy of the bone would also reveal necrosis or death of the bone. We treat this with IV antibiotics, including ongoing antibiotics for 4 to 6 weeks. We'll incise and drain or IND the abscess that's developed. We will debride or clean out the wound and then immobilize the patient and promote rest. Sometimes amputation is the only cure for severe osteomyelitis. Non-union of fractions or failure to heal. We can give them an electrical bone growth stimulating device. That uses electrical coils or electrodes to send electrical current into the bone, and that stimulates osteogenesis or the growth of new bone cells. If that works and we're able to grow the bone together, we don't have to do any further surgery or bone grafting. However, we would use surgery or bone grafting if that bone did not heal, despite the electrical bone growth stimulating device. Fat embolism. So this is your rare but serious complication of a fracture. This is where a fat globule enters into the circulation, and it either partially or completely occludes your blood vessels. Signs and symptoms of this: we have that change in mental status, respiratory distress, tachypnea, tachycardia. They may have crackles and wheezes when you listen to their lungs, a rapid pulse, right? That tachycardia. It might be bounding. Fever, petechiae, or that fine red rash over their chest, their neck, their upper arms, their belly. Put these patients in a high Fowler position and stay with them. This is an emergency. The doctor has to be notified immediately. Put in a peripheral IV if they don't have one already. We're going to do lots of hydration. We're going to have to correct acidosis. They're going to have to be intubated and mechanically ventilated in almost 100% of cases, right? 80% of the people that have a fat embolism die from their fat embolism, okay? Venous thrombosis, okay? Venous thrombosis, this is where the veins of the pelvis or lower extremities develop, most often, develop a clot, especially with hip fractures. We see this a lot. And immobility, right? Not moving their body. We've got some venous stasis, and we can develop a nice clot in there. TED hose, compression hose, sequential compression devices, range of motion exercises are going to keep us moving and help with venous return. Aspirin, heparin, Lovenox, warfarin may be ordered both to prevent a venous thrombosis and also to treat a venous thrombosis. Compartment syndrome. So this is an emergency. It's where we have restricted circulation caused by either external pressure, like from dressings or casts that are put on too tight, or internal pressure, where we have maybe an IV infiltrated, or tons of inflammation and swelling, or a fluid shift, right? And so that increased fluid is putting pressure on those tissues and the nerves and the blood vessels, and there's no blood flow to the extremity. And that pressure occurs in one or more muscle compartments surrounded by fascia in the extremities. This is a severe, unrelenting pain. And we're going to be assessing for those 6 P's. Is it painful? Is it pale? Does it have feeling? Does it have a pulse? Can it move? And is it cold? Pain, pallor, paresthesia, pulselessness, paralysis, and poikilothermia. I have a video, and I will say it is probably not the best video, but it is a Grey's Anatomy reference I'm going to share with you of an emergency fasciotomy, which is our treatment for compartment syndrome. What can the nurse do? We could bivalve a cast, so cut it from both sides. We can remove a dressing, right? What do we want to do? We want to lower the leg. We don't want to lift it up. Lift up a leg to prevent swelling. We lower a leg to promote perfusion. We want blood to get to that extremity, because our issue in compartment syndrome is we have no blood flow, right? We can also, obviously, the first thing we would do is notify the physician. This is an absolute emergency. And then we would prepare and anticipate maybe a surgical fasciotomy. That's where we do those long linear incisions down the legs most often to relieve the pressure, right? We allow that fluid to soak out either in the calf or the forearm is the most common places for this. So here is an example of an emergency fasciotomy from Grey's Anatomy.
Okay, now let's take a look. I'm going to shine a bright light into your eye.
Okay. Oh, so you knock it off. I did? Knock it off, man. Damn it. Just stay down there for a second. What kind of doctor are you? Military doctor, and this is my ER. You guys seem to think that our rules don't apply to you, and it's cost me 2 good surgeons today. So if one of you so much as makes a sound before you're discharged from my ER, I will send you out of here on a stretcher. Understood? Yes, sir. Yes, sir. Okay. Yes, sir. Sorry.
Oh, I like a man with authority. Me too.
Compartment syndrome, I'm going to need betadine and a scalpel. Scalpel? What are you going to do? I need to release pressure or you're going to lose your leg. So, close your eyes, okay? Yes, sir.
Nasty.
I said close your eyes. Don't you ever do what you're told?
I know that's pretty gruesome, but that is the reality of an emergency fasciotomy. It's just splash and dashing it, right? You've got to throw that betadine on there, or the doctor, excuse me, has to throw that betadine on there and cut that linear incision all the way down the compartment, that fascial compartment that contains the swelling or the fluid or blood accumulation. Okay, so recognize the symptoms, notify your doctor, bivalve the cast or cut it off if possible, cut off or replace the dressings, loosen them if possible, and then prep for that fasciotomy. How to prevent this, and that's our best thing that we can do, is to elevate, elevate, elevate. But how do we treat it? We lower it in order to promote perfusion. That's a good image of the fascial compartments of the calf. You can see how those muscles are wrapped up in that fascia, and they're just slicing into that to allow that fluid to escape. Lyme disease. Okay, so we're going to take a little turn. We're going to move towards our inflammatory musculoskeletal disorders. Okay, Lyme disease causes it's also called Lyme arthritis, is caused by a systemic infection by the spirochete borrelia. So the spirochete is transmitted with a bite from a tick, right? Either a black-legged or a western black-legged tick. We see this in New England, some mid-Atlantic states, sometimes the upper Midwest, California, and Oregon are areas that are most known for Lyme disease. Starts with those flu-like symptoms, kind of vague, and then we develop that typical or indicative bullseye rash. Joints and muscles may be pain, they may be stiff. We may develop a carditis, which is an inflammation of that cardiac muscle, maybe a meningitis, a peripheral neuritis, or a facial paralysis, general fatigue or issues thinking clearly, arthralgia, or a mix up of the things that we say, and we're not able to recognize things anymore. Treatment of this, how do we treat it? Well, first of all, we have to diagnose it. So we're going to look at that clinical presentation. And then if we have that possibility of being exposed to infected ticks, we want to do some just treatments, right? We're going to throw some IV antibiotics at it. We won't really see any lab changes until we go into that stage 2, so 2 to 12 weeks later. And then we've got other issues, right? Other sequela from the tick bite and from the Lyme infection. So we want to just give them antibiotics for that infection. Okay. Osteoarthritis. It's a non-inflammatory degenerative joint disease that can affect any weight-bearing joint. Now, I'm going to bring attention to the word non-inflammatory. Previously, it's been called non-inflammatory, but now we know that this disease process is inflammatory, and that label is no longer correct, right? We have a breakdown of our bones, synovial joints, cartilage, right, which causes inflammatory molecules to be released. Therefore, it is inflammatory. We don't know why this happens, but we do know that heredity, aging, being a woman, being overweight, having a previous joint injury, or recreationally or occupationally using the joints over and over and over again are going to be risk factors. Okay, osteoarthritis is usually asymmetrical. It's only happening on one side of the body and affecting 1 or 2 joints. It's a lot of aching pain, stiffness. Maybe they're not able to move as well as they used to be. They may have a deformity, nodules or spurs may develop. Pain management, we're going to give them aspirin or salicylates, Tylenol, acetaminophen, maybe up to 1,000 milligrams, 3,000 milligrams per day. For mild to moderate chronic joint pain. Also NSAIDs to reduce inflammation. Get them on strengthening aerobic exercises, help to reduce their weight so that we're not straining the joints as much, helping to maintain joint function through therapy and range of motion exercises. And then also complementary and alternative therapies can be offered as well. NSAIDs may not be recommended for your older adults because there are side effects, and they also interact with other medications like ACE inhibitors used with like hypertension or heart failure, and also it can thin the blood or increase the effects of anticoagulants. So that is something to think about. As well as complementary and alternative therapies, yoga, massage, capsaicin cream, something like that in order to reduce inflammation and promote comfort. We want to balance exercise and rest, apply moist heat, get that weight reduction going on so we can decrease joint stress and help with imagery, relaxation, diversion, right? These people are often put on glucosamine and chondroitin to decrease their pain and the development of their osteoarthritis, etc. Okay. Rheumatoid arthritis. Now, rheumatoid arthritis is different because it's not just inflammatory, it's autoimmune. Okay. Rheumatoid arthritis is an autoimmune response to an external trigger that results in inflammatory disease of the joints. Any age, right? It can happen at any age, but older women are most likely to develop rheumatoid arthritis. There may be hormonal, environmental, genetic, or infectious agents that trigger this and causes autoimmune reaction to take place. Now, abnormal immune response causes an inflammatory reaction inside those synovial membranes. We have vasodilation, we have exudate formation, and we get those red swollen joints. We also see that rheumatoid factor, right? The antibody against immunoglobulin G appearing in the blood and synovial fluid accumulating in many patients. Now, with this disease, we have remissions and exacerbations. So there are periods of time where we don't have as much issue with it, and then it can flare up. Pannus is that granulation tissue that comes from the synovium, and it can spread over all the articular cartilage and release enzymes and inflammatory mediators to destroy that cartilage. And as that cartilage goes away, that pannus cuts off nutrition to it, and the pannus between the bone ends starts to become fibrotic. So we've got ankylosis, joint fixation, deformity, and all kinds of really terrible, oftentimes permanent changes. Atrophy of muscles around the joint, stretching of tendons and ligaments, instability of the joint, muscle spasms, contractures, deformities, right? We see a lot of that. And then subcutaneous nodules may form over the bony prominences. So like pleura, heart valves, and eyes can also develop nodules as well. Joint pain, warmth, swelling, limitation of motion, multiple joint stiffness. So this occurs through many joints throughout the entire body. It's also symmetrical. It's often on both sides. Systemic symptoms, you may start to see a low-grade fever, loss of appetite, weight loss, general poor feeling, iron deficiency anemia that doesn't respond to iron therapy, right? All of those things. The big focus within treatment with these is pain. Let's talk about diagnosis. So we're going to do those blood tests, the C-reactive protein, erythrocyte sedimentation rate, rheumatoid factor testing. They have arthritic pain in 3 or more joints for greater than 6 weeks, and they have morning stiffness that lasts more than an hour. Imaging will also show that we've got that cartilage destruction and bone deformities. Pain, pain, pain with rheumatoid arthritis. Treat their pain. With people who have chronic conditions, narcotics are not recommended. We want to minimize joint destruction and help to promote joint function and their ability to perform self-care. So we want to get them on medications like DMARDs, NSAIDs, TNF inhibitors, salicylates, maybe steroids. Anti-malarials can work off-label for rheumatoid arthritis, maybe methotrexates or gold compounds, sulfasaline. All of these medications work in many different ways. For example, methotrexate is a first-line DMARD, right? It can be given to patients in order to change the way that the body attacks itself. It is disease modifying. Other medications can help with reducing inflammation. Okay, I think that's it for this page. Okay. Rheumatoid arthritis surgical interventions. We may use casts, braces, splints to immobilize the affected parts. We can rest, especially when we've got an exacerbation, but it should allow for motion of all the other muscles around it so that we have potential for improvement of muscle strength and independence for the patient, right? We may do a synovectomy or an excision of the synovial membrane around the joint. This would help to interrupt the destructive inflammatory process that would lead to the ankylosis and invasion of surrounding cartilage and bone tissues, or an osteotomy, especially if the patient is younger. Go in and we're going to take out a part of the bone so that the bone can realign. Tendon reconstruction. Frequently this is done in the hand in order to restore function. And then we've also got joint replacements. Now these are last case options, especially with rheumatoid arthritis, because all their joints would end up having to be replaced and may even require continual replacements, or replacement every 10 to 15 years. But they do end up with total hips and total knees. If we see improvement within 2 weeks, the patient's pain is controlled with meds, heat, and exercise, that would be great. If we have improved mobility and ability to use our assistive devices with PT in 3 weeks, that would be awesome. And within 1 month, we want these patients to have improved body image and be able to participate in social activities. These are expected outcomes for care plans for your rheumatoid arthritis patients. After a patient has had a total hip, we need to make sure that they know for 3 months they cannot cross their legs, that they can put a pillow between their legs when rolling over or lying on their side in the bed, that it's okay to bend their hip, but they don't want to overbend it, right? Not beyond a 90-degree or right angle. We don't want them sitting in low chairs where it takes a lot of effort and a lot of strain on that hip in order to get up, and making sure that they're continuing their daily exercise program. Okay, we're going to talk about gout now. So, what is gout? Well, gout is an arthritis in the joint that's caused by high serum levels of uric acid. Uric acid crystals precipitate from the body fluids and end up settling in these joints and connective tissues. Men are more likely to be affected than women, and it usually starts to set in around middle age, especially if the patients are consuming a high protein diet. They are at high risk for this. There's a possibility for a genetic increase in purine metabolism, which can cause that overproduction or retention of uric acid. And also if you're eating a high purine diet. Excessive alcohol consumption will cause an increased production of keto acids that inhibit uric acid secretion and can cause hyperuricemia. And then deposits of urate crystals occur in the joints and subcutaneous tissues and can cause kidney stones. The big toe is most often affected. It's the most common site. Many other joints can be affected as well. If the patient is on diuretic therapies, there may be a secondary gout that results from fluid loss, which would increase your serum uric acid levels in the body. Also, certain drug therapies may interfere with uric acid excretion and cause secondary gout as well. Pseudo gout is caused by calcium pyrophosphate crystals and is also called calcium pyrophosphate disease. The symptoms, pathophys, acute treatments are very similar, but the causes are different. So what do we see? We see that tight reddened skin over the inflamed, swollen joint with an elevated temperature and extreme pain in the joint. We also see an elevated blood uric acid level. We diagnose this with a history and physical, especially a family history. We look at their serum uric acid level. We treat with NSAIDs for 2 to 5 days, followed by a medication. Colchicine is given orally and may really help with pain relief within 24 to 48 hours. We may also give oral prednisone or do cortisol injections for these patients to help with pain. Allopurinol, probenecid, lesinurad, or febuxostat may be prescribed to prevent further gouty attacks. IV infusions of pegloticase may be used in patients that aren't responding to other medications. We really want to make sure that we talk to these patients about high purine foods, and we want to reduce the amount of high purine foods that are being consumed. Things like anchovies, sardines, sweetbreads, liver, bacon, kidneys, venison. Restrict their alcohol. All forms of ingestible alcohol contain high levels of purine. Also, if you're on allopurinol, that medication, you need periodic liver function testing because this drug can cause liver failure. Drinking lots and lots of fluid, 2 to 3 liters a day, to help protect the kidneys from urate crystal deposits and prevent kidney stones. Okay, so we want to be sure that people that are on allopurinol are getting regular LFTs, but we also want to make sure that if they have decreased creatinine clearance, that they're not taking allopurinol, because that can be an issue as well. If the patient has both hypertension and gout, losartan or Cosar may be a good choice for therapy because it both helps with the high blood pressure and the urate excretion. Osteoporosis. Osteoporosis is the loss of bone density, right? It makes the person more susceptible to fractures because we lose bone mass. These are called fragility fractures. You don't even need a trauma and you can have a break. Osteopenia is the predisposing condition to osteoporosis. This is where you have a low bone mass, but not enough to call it osteoporosis. Osteoporosis actually causes more disability and the shortening of life than rheumatoid arthritis. It's often underdiagnosed and undertreated. There is a hereditary aspect, so it can run in families. Risk factors include aging, right? Chronic diseases, having an underlying issue like in the liver, lungs, or kidney, being on medications like steroids, anticonvulsants, anticoagulants, PPIs, SSRIs, having a long-term calcium deficiency, not taking in enough vitamin D to synthesize the calcium, smoking, drinking a lot of alcohol or caffeine, and not moving the body enough to build healthy, strong bones. Eating disorders and inflammatory bowel disease can also lead to osteoporosis because they interfere with nutrition and absorption of those things that we need to make strong, healthy bones. As women age and start to go through menopause, estrogen is reduced, and therefore there's a greater risk of osteoporosis. Your older women are the most likely to develop osteoporosis. Now, there are no early signs and symptoms of osteoporosis. It is a silent disease. But once the osteoporosis has really taken effect, you may have height loss, kyphosis, or that excessive curvature of the spine, and back pain. Compression fractures may also occur, and those become very painful. Once we have a fracture from little or known trauma, one of those fragility fractures, we are often diagnosed with that osteoporosis. We diagnosed it also with those DEXA scans that we talked about. During a DEXA scan, you get a T-score. That T-score will tell us how dense the bone is. In normal bone density, we see a T-score of greater than 1 standard deviation from the healthy young adult. Osteopenia would be a T-score of 1.5 to 2 below a healthy young adult, and osteoporosis is 2.5 to 3 below that healthy adult number. So below negative 2.5 is osteoporosis, negative 2.5 or more, osteopenia, and then 1 or less is good. Okay. Or excuse me, 1 or more is good. Osteoporosis, what are our goals? We want to stop the loss of bone density. We want to increase new bone formation. We want to prevent fractures. We may have to replace the estrogen in our women. We may have to talk about increasing our dietary and supplemental calcium and vitamin D intake. Teach them about weight-bearing exercises to strengthen their bones. They may be put on biphosphonates or parathyroid hormone supplementation. Osteoporosis and vertebral fractures. So vertebral compression fractures commonly occur in patients that have osteoporosis. We give these patients lots of pain medication. We help limit their activity, get them into PT. We provide them with braces. There are some options for these patients. We can do a vertebroplasty or a kyphoplasty to help them. Vertebroplasty involves the percutaneous injection of PMMA or polymethyl methacrylate, which is a cement, right into the osteoporotic spinal area under fluoro, and that actually cements it together and keeps it nice and strong. It stabilizes the bone and helps reduce or eliminate pain from the shifting or compression that occurs inside of that porous bone. Kyphoplasty is where we do a percutaneous injection or insertion of an inflatable device that actually puffs up and reduces that pressure, right? It restores that vertebral body toward its original height, and then we put in that cement under that low pressure of the cavity, and then we can deflate that device and remove it, and we have reduced the kyphosis. Okay, Paget's disease. So this is a problem of abnormal bone resorption, right? And then we have an issue with replacement of normal bone marrow getting replaced with the fibrous connective tissue. Abnormal bone is very weak. It breaks very easily. We don't know what causes this necessarily, but it does run in families. The disease is found whenever we have a fracture, and then we do radiographs and find out that we have abnormalities in the bone. 24-hour urine collection is important. It'll come up with urinary pyridinoline collagen cross-link assay results, which would indicate osteoclastic activity or bone breakdown activity. We also may do a serum alkaline phosphatase, and if it's elevated, we would know that this Paget's disease is active. These patients have a lot of pain. We can give them miacalcin or a biphosphonate to slow their bone reabsorption, but they need orthopedic care for their fractures, right? Potentially joint replacements. We need to make sure they've got a nice firm mattress, that they may wear a brace or a corset to relieve their back pain, and that we teach them the appropriate body mechanics to avoid lifting or twisting so that they don't cause issues like fracture or stress on this weak, abnormal bone. Bone tumors. Bone obviously can get tumors, both benign tumors and malignant tumors. Tumors can come from different types of tissue: cartilage, which causes your chondromas; bone, which are osteomas; or fibrous tissue, your fibromas. Benign tumors are often found with an x-ray, or we have a fracture and we discover the tumor. Malignant bone tumors are either primary or secondary to a metastatic disease. So you either have a true bone cancer or it's moved to the bone from a different type of cancer. So diagnosing and treating cancer in other parts of the body can prevent metastasis to the bone, but it also can tell us that we might potentially have metastasis to the bone. Other types of primary malignant tumors include Ewing sarcoma, chondrosarcoma, fibrosarcoma. We have a lot of pain, warmth, swelling at the site. We do x-rays, bone scans, and biopsies. Remember, bone scans tell us about tumors. We do surgery to remove the tumor, to resect the bone if necessary. We give chemo, radiation in order to treat the cancer, if that is the case. We also may give a medication called Zometa or zeledronic acid to treat hypercalcemia associated with bone tumors. Okay, patients may be very anxious and fearful, especially if it's a cancerous bone tumor. So we want to provide lots of psychosocial support. Amputation. So most of the time we're talking about a lower limb amputation, something like peripheral vascular disease, diabetes mellitus, gangrene. We've had a trauma, we have cancer, or there's a congenital defect or military injury that requires an amputation. Upper limbs are usually amputations needed because of a crush injury, a severe burn, a severe laceration, maybe a vasospastic disease that's resulting in prolonged or continual ischemia to tissues, cancer, or infection. After we've accidentally amputated something, we need to rinse that detached body part enough to remove that visible debris. We want to wrap the body part in a clean, damp cloth, place that body part in a sealed plastic bag or in a dry watertight container, and then put whatever we've put it in into a mixture of water and ice. So lots of ice water. We don't want to let the body part get wet or freeze, but we want to keep it cool. Instead, we could also place that container into an insulated cooler filled with ice. If we don't have ice, we just want to keep it cool and not expose it to heat. And then we need to tag that bag or container with the patient's name and the name of the body part, and then take it to the hospital with the person. And sometimes they're able to reattach or re-implant the amputated part. So it's important we teach the public and we get the information out there about what to do with an accidental amputation. Preoperatively with an amputation, we want to make sure we're including the patient in participation. They need to help to decide that amputation is the best course at this time, if possible. Sometimes it's not possible, right? We also need to teach them what to expect post-operatively: pain, immobility issues, readjustment to how to care for themselves. We need to talk about realistic goals of rehab, especially with PT and OT. What can we expect to be able to accomplish? Family needs to be involved in order to get everybody on board so we know what to expect. Patients are actually probably going to go through stages of grief, so denial, anger, and so forth, because they're losing a part of their self, and they're going to be a part of their former self is going to die. They're going to go through this grief process as they accept the fact that they have a new body or a different body after the amputation. They may also develop phantom sensations. That's where we removed a part of the body, but the spinal cord and the brain have had an issue with rewiring. And so they're sending signals that the limb is still there and it is painful, even though the limb is no longer there. We also want to physically prepare these patients for the amputation, so we can strengthen muscles to help with the activity after the amputation, like their arm muscles if they're losing their legs or something of the sort. Those exercises are first stages in your rehab process to help the patient achieve independence as quickly as possible. Post-operative care, Our priority is going to be for hemorrhage, right? We're going to worry about hemorrhage, bleeding, that's your ABC, circulation, also swelling in that residual limb. We want to elevate that limb for 24 hours. We want to watch for excessive bleeding. We want to look at that dressing first thing so we can see if we're saturating the dressing too quickly. So the two most immediate problems after amputation are hemorrhage and swelling or edema. We will elevate the stump for 24 to 48 hours, except for if it's a lower extremity. We don't want to elevate for more than 24 hours because we can get a hip contracture, right? That would be a bad news bears. So we don't want to do that. We're going to get prophylactic antibiotics for 3 to 4 days. And we may put in like a wound vac or a wound drainage system of some sort. Keep that incision nice and dry and intact. We would expect to see maybe some redness around the suture line, but just slight redness, no more than that. And then that pressure dressing is removed by the surgeon after 48 to 72 hours. Phantom limb sensation. So we talked about this a little bit. They may or may not be painful. We can give them some ketamine right after to help to prevent these. We also, if the pain is severe or it persists, we can do other things like a TENS unit, the transcutaneous electrical nerve stimulator that distracts the body from the pain. We may also apply a stump stocking. It's a silicone liner with electromagnetic shield in it, and it blocks external electromagnetic impulses from outside sources that can irritate those nerve endings and cause phantom nerve pain. We also can apply virtual reality goggles to help them visualize the missing limb and see it as whole and uninjured. And we can trick the brain into thinking that everything is good. Alternative modes for managing the stump after amputation, we can apply a soft dressing and do a prosthetic fitting later. We can also do a rigid plaster dressing with an early prosthetic fitting, or a rigid plaster dressing with an immediate prosthetic fitting. Just depends on the patient and their readiness. Adequate healing is super important for weight bearing. If we're weight bearing before we're ready, we can cause issues with the healing process. Below the knee amputation people are better to start walking and weight bearing than above the knee amputation. That takes a lot longer to heal. Abduction contractures can happen if we elevate the leg for too long, right? Also, we want to make sure we're positioning the leg, because if we pull it in towards the body, like we pull in the stump towards the knee, we can cause that contracture toward the body, and it will get stuck in that position. So that's super important. The patient has to adjust to this new center of gravity, right? Especially if they've lost a lower limb. They need to learn how to balance on one leg, how to bend over without losing their balance, how to use their back muscles, especially when they're wearing that artificial limb. We need to teach the patient about how to care for their stump, right? How to do activities and bear weight safely, how to exercise to promote loss of muscle structure, and then that they need to go to rehab in order to increase their ability to perform their ADLs. Here is a cute picture of a lady with a sea leg prosthesis, and she is using it to dance. So we do know that they are able to successfully use prosthesis without assistance, eventually in most cases of amputation, and they're able to live a normal life. So there's lots of psychosocial support that goes into this, new body image they have to adjust to, but being encouraging and getting them involved in support groups and community resources is going to be big. And that is the end of your chapter 32 lecture / PowerPoint. I know it's a lot of material. I hope that it was helpful for you, and I will see you in class.